Good afternoon, everyone. This is Team 9 with members Cameron Bush, John Diamond, Reagan Homer, Sean O'Donnell, and Catherine Sayo. And today we are discussing ethical concerns in healthcare during times of crisis and overcapacity. The ethical problems we are looking at are a direct result of the current situation the world faces and the ethical choices that must be made for the greater good of society. None of our team members work directly in the healthcare industry and wanted to learn more about what choices are being made affecting public policy. What do medical systems do when struck with capacity limitations? When resources such as equipment, supplies, staff, or bed capacity start to be scarce, what will happen? Who will be treated and who will be turned away? Will potential patients receive minimal or no treatment? Will care be refused? If you are not in need of emergency care or afflicted by the current crisis, will you be turned away? Will medical systems create a hierarchy of who receives care first? Other than emergency care, will elderly be pushed to the back of the line for crisis care? When looking at groups that would benefit from medical systems being overcapacity due to a crisis, there are not many we consider to benefit. Some are rather grim benefits. To start off with, patients with high likelihood of survival will likely receive preferential treatment. There are several articles describing the potential for medical systems having to decide to turn away patients with low likelihood of survival due to the health or age in the current COVID-19 pandemic if it had gotten worse. These articles are over a month old now, and the pandemic has gotten significantly worse in certain parts of the world. Emergency preparedness researchers and managers will benefit from the vast research data available following the crisis to better inform for future events. On a similar note, medical system contingency planners will be able to develop best practices after a large-scale event due to reviews of what went right and what went wrong. Social Security taxpayers and future recipients would benefit if the elderly and sick were turned away due to resource constraints and were to pass away. Less people pulling from the benefit pool, grim benefits, remember? Medical equipment and device manufacturers will benefit from extreme demand of products increasing their revenues. Any donation of supplies or equipment will be a tax write-off and public relations boost.
The obvious groups who will be harmed are the patients who are denied treatment due to overcapacity of the medical system. It is inevitable that some patients will receive priority over others because of resource constraints, leaving some patients to die or suffer without medical care and observation by medical professionals. Medical staff are also harmed mentally and physically in this dilemma. They must extend their work hours to meet the influx of patients, resulting in less sleep and increased stress, which can put them at greater risk of contracting the virus. From a mental standpoint, they will have to deal with the fact they are turning away some patients that are ill and require attention but have no capacity to help. Also, family members of patients turned away will be harmed emotionally and financially with the loss or illness of their family member. They will have to live with the fact that their loved one passed away without proper care and may likely never emotionally heal. Medical systems have discussed implementing a blanket do not resuscitate order, which could harm some patients accepted for treatment. At any point, should the patient require CPR or other artificial life support such as a ventilator, it could be denied to protect the health of the caregivers and preserve resources for other patients. In addition, patients who planned elective surgeries will be harmed by having their appointments canceled, and depending on the type of elective surgery, it may have been needed for mental or emotional wellness. Though the COVID-19 pandemic has a widespread effect, the virus disproportionately affects the low-income population, immigrants, people of color, and low-wage or hourly workers who are often uninsured. The uninsured have significant barriers to get tested and treated for COVID-19 because of their lack of access to healthcare and healthcare coverage. Many of these individuals are elderly and lack health insurance or are workers who have jobs with increased exposure to the virus. These include people like retail workers, waiters and waitresses, and housekeeping staff. Congress has enacted some legislation to help address the rights of those who may have been affected most by COVID-19, the uninsured and those who are unemployed, but inevitably cannot reach everyone. The Families First Coronavirus Response Act has provisions for emergency paid sick leave, but only for businesses with less than 500 employees. Also, the legislation is not retroactive, meaning those who already took sick leave are excluded from being compensated. The Families First Coronavirus Response Act also reduces barriers to testing and treatment by expanding Medicaid coverage to uninsured in their state to provide coverage for COVID-19 diagnosis and symptoms with federal financing. Unfortunately, the cost of treatment for the virus are not covered for those who are uninsured. COVID-19 has not only affected those being tested and treated, but has also impacted the healthcare professionals on the front lines. With hospitals running low on resources, the healthcare workers are forced to reuse personal protective equipment, or PPE, putting their health at greater risk. The rights of these individuals are being ignored as hospitals are not supplied with sufficient equipment to protect their staff and the health of their patients. There is currently legislation being developed to address such issues, but has not been passed into law. This act would implement workplace protections and create standards for safe conditions and safety measures to protect healthcare workers and the patients they serve.
To properly understand, assess, and evaluate a moral solution to this moral dilemma, it is important to ask and answer the question, whose rights are being exercised? In this ethical dilemma, decision makers are the main party whose rights are being exercised. In a global pandemic, each country is responsible to establish its own protocol for emergencies. In the United States, decisions are made on a state level. In Utah, there is an official state government crisis guideline document called Utah Crisis Standards of Care Guidelines. This document defines specific decisions that should be made in times of crisis. The Crisis Standards of Care specifically states the conditions that a health professional must use to determine whether or not to treat a patient due to an uncontrolled influx. These guidelines help hospitals prepare for crises before they happen by having an approved plan ready that has been ethically evaluated and approved by experts. Although these guidelines are set by the Utah state government, they are still just guidelines. Hospital administrators and doctors must make the final decision as each situation arises.
There are few economic benefits when it comes to healthcare professionals denying high-risk COVID-19 patients healthcare. Those who are diagnosed or even symptomatic and are denied medical attention will likely not be able to return to work, go out in public to get necessities, or even seek help elsewhere without the risk of exposing other individuals. As a result, their economic stability will likely worsen, and they may not be able to meet their current and long-term financial obligations. This dilemma, magnified across many affected individuals, could have severe negative downstream effects for impacted parties. Those who lose their jobs due to these circumstances and file for unemployment increase the burden on the Department of Labor's unemployment insurance resources, potentially leaving many states short of their already strained fund reserves. Insurance companies who have financial obligations towards individuals and companies may be negatively affected by those caught up in the dilemma of who receives treatment. Health insurers of individuals who do receive medical attention may face greater coinsurance and out-of-pocket liabilities. Companies may see a dramatic increase in their death benefit payout obligations due to an increased death rate among policyholders who are affected by COVID-19. Including those who were denied medical attention. Other insurance companies may see an increase in workers' compensation claims against employers who do not adequately accommodate virus prevention measures. The insurance sector has historically been well established with long-term capital and liabilities to withstand any economic disruption. However, increased market volatility, decreased bond yields, and slashed interest rates from banks due to responses to COVID-19 may cause negative short and long-term economic effects against these companies. Lastly, it can be assumed that directly prioritizing lower-risk individuals will increase the probability that more healthy individuals return to the workforce. Given the strong correlation between healthy, productive populations and strong economies, it is probable that those who are more likely to recover will more quickly result in a healthier workforce and spur long-term economic recovery, growth, and contributions to society.
It may seem that the law should be suspended or relaxed in favor of those responding to a declared emergency, but it is not for the most part, especially in requiring that medical professionals adhere to adequate standards of care. The nature of exigencies, though, leads to the Pennsylvania Health Department's attribution that in the midst of a crisis, there is a very real risk of providing a lower standard of care than is necessary under the circumstances. While most states have provisions that limit legal liability during emergencies, those provisions tend to limit medical malpractice liability for ordinary negligence, leaving providers subject to claims of gross negligence or willful disregard of standards of care. Utah does not relax standards at all, but its version of the statewide Mutual Aid Act grants those responding to a request for assistance the protection of both pre-existing Utah law as well as that of the responder state, whichever is more protective. Some states attempt to deal with the issue by deputizing medical and other needed professionals as official state actors, who enjoy greater immunities than private actors. Now, the fact that circumstances change quickly makes analysis of legal duties difficult, if not impossible, from moment to moment. Once an emergency has been declared, by design, the legal landscape changes. It changes instantly and can change drastically, depending on how it changes, the legal responsibilities and liability protections and altered standards of care issues come into play. And none of this helps the decision at the moment. For example, allocation and withdrawal of scarce ventilators is the current issue illustrating the problem. While medical ethicist view considers many factors other than prioritizing patients most likely to survive treatment, the legal framework is not necessarily as broad, especially once care is assumed for a patient for whom withdrawal of the ventilator would be a death sentence. Considering the ethical duties, first, considering long-term interests. Well, the medical personnel who are essentially the first responders here are putting themselves in immediate harm's way with little or no short-term benefit to themselves. They're there to help and volunteer their service, but in the long term, they'll become better care providers with the experiences that they have. Regarding personal virtues, medical systems and professionals are being tested for their personal virtues. They've been trying to be truthful and open to the communities about the dire situation, but some groups in the communities are stoking fear and causing a commotion because they don't believe what's being said. Regarding religious injunctions, medical systems have been reacting to the crisis with frequent outreach and assistance to their local communities via social media to ensure that the community is aware and prepared for the crisis. Regarding government requirements, the law requires medical systems to care for all patients in emergency situations. A potential patient cannot legally be turned away, but they can turn away people deemed not having a medical emergency. This is currently being heavily used in the current COVID-19 pandemic to deny non-emergency care. Utilitarian benefits. Medical professionals are forced to answer how to prioritize patient care according to their capacity as well as to reduce the overall harm to society. This may not seem a greater good to those who are denied treatment, but serves to ultimately save more people in the long run. Regarding universal rules, medical professionals in this situation would be forced to make a decision that others would not wish to be forced to make, let alone freely make. As such, they will make their decisions to the best of their medical competency and based on the probability that those who will receive treatment will survive compared to others. Regarding distributed justice, laws and legislation exist that provide care and medical coverage to those who are uninsured and unable to pay for medical costs due to job loss or illness. And regarding contributed liberty, this will effectively not be followed as patients are turned away from medical treatment. There will also be individuals in communities who are afraid and take resources away from medical systems to get treated under false pretenses, taking that resource away from someone who would actually require treatment.
In conclusion, a global pandemic, mass casualty event, or other event causing significant strain on the medical system at all levels represents an immense ethical dilemma for medical professionals forced to make life-saving, or life-altering decisions. These situations will affect communities much more if they are not prepared to face them ahead of time, or if they do not have adequate resources at their disposal. Ethical dilemmas presented in times of distress are made even more complicated by the unpredictability of the situation, interests of those affected, and the emotions of those involved. In the case of COVID-19, healthcare professionals are faced with decisions that have life or death consequences, and everyone at varying degrees will be faced with a moral or ethical dilemma. Because of the complexities of these dilemmas, it is important to use a framework to understand, assess, and evaluate a moral solution by considering multiple perspectives.